Hi, welcome to our channel of IGNOU audiobooks, Indira Gandhi National Open University, School of Health Sciences, SOHS. Postgraduate Diploma in Maternal. Pregnancy termination or induced abortion, particularly for a normal pregnancy, is associated with emotional change, superstition, and religious taboos. It involves social, political, and economical issues in every country. Termination of pregnancy has been practiced since historical time. Because of its greater safety as compared to the childbirth, abortion has obtained tremendous popularity in the last few years to get rid of unwanted children. It also has great impact on population control. It is never recommended as a method of contraception. Let us now go into the further details about MTP. 5.2 History and Definition. From the historical times, termination of pregnancy has been practiced with or without legal and social sanctions as a solution for unwanted pregnancies. Maternal morbidity and mortality due to complications of unsafe or illegal abortions constituted a major public health problem. Hence, in India, Shantilal Shaw Committee formed in 1964 recommended liberalization of abortion law in 1966. In 1971, MTP Act was passed by Indian Parliament and implemented in 1972. In 1975 October MTP rules were notified. These rules were further amended in 1977. What is meant by induced abortion or termination of pregnancy? Induced abortion defined as willful termination of pregnancy before viability, i.e. before 20 weeks of pregnancy. 5.3 Guidelines for MTP. Now we will go into the details of MTP Act and rules. The MTP Act specified 3 conditions. L. Time when a pregnancy can be terminated. L. Person who can perform MTP and L. Place where MTP can be done. When can pregnancy be terminated? A. If pregnancy endangers the life of the pregnant woman, i.e. if mental or physical health of the woman is affected by the pregnancy. B. If baby is to be born with serious physical or mental abnormalities. C. Pregnancy caused by rape. D. Pregnancy due to failure of contraception. Who can perform termination of pregnancy? A. Up to 12 weeks of pregnancy MTP can be performed by a registered medical practitioner having experience in obstetrics and gynecology only. B. If the pregnancy exceeds 12 weeks and is not more than 20 weeks, the opinion of 2 registered medical practitioners is necessary to terminate the pregnancy. Where can abortion be done? A. A hospital established and maintained by government. B. A place or hospital approved for this purpose by government. Abortion services are provided in hospitals in strict confidence. The name of the abortion seeker is kept confidential. MTP Rules, 1975. The conditions specified in the MTP Act were altered in 1975 to make MTP services more readily available. These changes have occurred in 3 administrative areas. L. Approval by board. Under the new rules, the chief medical officer of the district is empowered to certify that a doctor has the necessary training to do MTP. L. Qualification required to do abortion. A. 6 months housemanship in obstetrics. C. 3 years of practice in obstetrics and gynecology for those doctors registered before the 1971 MTP Act. D. 1 year of practice in obstetrics and gynecology for those registered on or after the date of commencement of Act. A. The new rules also allow the medical practitioners to qualify through spot training. To qualify, the practitioner must assist 25 cases of MTP in an approved institution. F. The place where abortion is performed. Under the new rules of 1975, non-governmental institutions may also take up abortion services if they obtain a license from the chief medical officer of the district. Consent for MTP prescribed in MTP Act. A written consent of woman desiring MTP is taken. In case the girl is below 18 or the woman is mentally unsound, a written consent from the guardian is necessary. Community awareness. In India, about 6 million abortions occur every year. Out of these, 4 million are induced abortions, but very few of these are reported and the remaining are done illegally. This is either due to lack of awareness in the community or due to lack of easy availability. Hence, methods like mass media or simple posters in regional languages are advocated for. The awareness of community. The media must emphasize the easy availability in Confidentiality of free, safe and legalized abortion services. MTP and contraception. After an abortion, about 75% women ovulate within 20 days. Approximately 6% of women will conceive in 4 to 6 weeks after abortion. Hence, proper contraceptive must be given at the time of abortion. The couple will be highly receptive at that time. Best method of contraceptive is sterilization if woman has 2 or more children. Suppose the woman has 1 child, temporary methods of contraception are recommended. Counseling. Proper counseling in women coming for MTP is very important. It is important to answer queries and to remove apprehensions and misconceptions. The psychological preparation of women leads to better cooperation. Counseling is done concurrently for contraception. Privacy and confidentiality is to be assured at every stage. 5.4 Selection of a patient. In induced abortion, period of gestation is the most important factor. Only women who are less than 10 weeks pregnancy should be considered for outpatient termination and MTP. Beyond 10 weeks must be done in a place where facilities are available to treat complications. History. The important points that you must inquire about are: A. Present or past history of any major disease. B. Any previous surgery. C. Menstrual history and date of last menstrual period. D. Obstetric history with special inquiry regarding any previous cesarean section. A. Previous MTP. Physical examination including vaginal examination. General physical examination is very essential. This includes recording of temperature, pulse, BP and systemic examination. You must look for anemia. A thorough pelvic examination is very essential. This will help you in A. Evaluating the size of the uterus. B. To rule out any pelvic inflammatory disease or neoplasm, like fibroids or ovarian tumors. C. To detect any local infection. Investigations. You must do routine investigations like HB% and urine examination for albumin and sugar. One more important investigation is blood grouping and Rh typing. Special investigations like urine for pregnancy test and ultrasonography are done whenever necessary. Urine for pregnancy test is done only in cases of doubt about pregnancy. Ultrasonography is done to rule out associated pathology. After these investigations, the patient is ready for MTP. 5.5 Methods of first trimester pregnancy termination. The methods for first trimester pregnancy termination is discussed under medical methods and surgical methods. 5.5.1 Medical methods. The following medical methods can be used for first trimester pregnancy: PGE2 and PGF2A. The induction of abortion can be done by prostaglandin E2, PGE2, and prostaglandin F2A. PGF2A, administered as vaginal pessaries or IM injections. The drawback of the use of prostaglandin in first trimester are: incomplete evacuation in 3 to 15% requiring evacuation. Excess uterine cramps, 33%, gastrointestinal side effects like vomitings and diarrhea in 30 to 50% of cases in spite of antiemetics and antidiarrheals, bleeding which lasts for 10 to 12 days. Prostaglandins have not yet been able to replace vacuum suction for one street trimester MTP due to higher rates of side effects and less successful results. RU486, mifepristone. It is an antiprogestational agent. It competes with progesterone for the receptors in the uterus so that the progesterone is displaced and pregnancy cannot be sustained. Thus it acts as a abortifacient. For the process to be complete, prostaglandins are given after RU486 is taken. Prostaglandin cause uterine contraction and complete the abortion. It is effective up to 6 to 8 weeks only. The procedure takes several days and may require 2 or more visits to service providers. Bleeding or spotting may last up to 8 to 10 days. Cramping, nausea and diarrhea may occur. Heavy bleeding may occur in 2% of women and failed procedure need backup. It is approved by Drug Controller of India and is marketed in some states at present. To use RU486, backup facilities to complete abortion must be available. Success rate is claimed to be 90%. 5.5.2 Surgical methods. A. Menstrual regulation, MR. Menstrual regulation is done for delayed menstrual period up to 14 days, that is the period of Amenorrhea less than 6 weeks. Remember that Mr. can be done at any time after 35 days. And before 45 days from the first day of last menstrual period. Mr. is safe and easy Ackermann's cannula. Number 4 along with a 50 ml menstrual regulation syringe is used to do Mr. Patient is put in lithotomy position, vagina and cervix are cleaned properly within antiseptic solution like betadine. Number 4 cannula is inserted into the uterine cavity through the cervix. A negative pressure is created with the menstrual regulation syringe. This causes separation of the functional layer of the decidua, endometrium, which is aspirated into the syringe. For further details of technique and instruments used, please refer practical manual. Complications of Mr. are grouped into immediate and delayed. Immediate complications that you can anticipate are uterine perforation, syncopal attack, severe uterine cramps, cervical lacerations and hemorrhage. Delayed complications are persistent bleeding, incomplete evacuation and pelvic infection, ectopic pregnancy which has been missed and continuation of pregnancy. You must ask the patient to come for follow-up examination after 2 weeks and earlier if she gets excessive bleeding. Bleeding persists after 1 week. If she experiences severe lower abdominal pain. If pregnancy symptoms persist and also if she does not have menstruation within 4 to 5 weeks after the procedure is done. B. Suction evacuation or vacuum aspiration. MTP up to 8 weeks of pregnancy can be done safely as an outpatient procedure even in PHCs. Safest period for MTP is between 6 to 8 weeks. Complication rate rises by 15 to 30%. Beyond 8 weeks, MTP between 10 to 12 weeks should be performed only at a place where full facilities to deal with emergencies are available. Suction evacuation is done under intravenous analgesia and local anesthesia. General anesthesia is needed in nervous patients. The procedure of SE consists of dilation of cervix and aspiration of products. Different vacuum pumps or suction machines are available. They are electrically or manually operated. The pump should be capable of delivering a consistent negative pressure of not less than 600 mm of mercury. The cannulae used are made of either metal or plastic. The metal cannulae can be sterilized and used repeatedly. The plastic one are pre-sterilized and disposable. The choice of thickness of cannula is determined by the duration of pregnancy and usually corresponds to the gestation in weeks. For example, 8 weeks of pregnancy, 8 mm cannula is used. For 10 weeks, 10 mm cannula is used. First dilate the cervix to the extent so as accommodate the chosen cannula. Then introduce the cannula to the full depth of the uterine cavity and apply suction. Move the cannula back and forth rotating through 180 degrees sideways both clock and anti-clockwise within the uterus and the products are sucked out. Stop when you have a gritty feel, then you do a curettage by a blunt curette. Do not do too vigorous a curettage. Post-operative care and follow-up. Administration of routine antibiotics following SE. Hence, advise her to use suitable contraceptive measures. If patient is willing, an IUD cut can be introduced at the end of MTP. Ask the woman to report for routine check up after 2 weeks, but advise her to come earlier if she develops any of the following symptoms: acute pain in abdomen, rise of temperature or persistent pain for more than 7 days, heavy or persistent fresh bleeding, persistent pregnancy symptom. In case of acute pain, suspect ectopic or acute pelvic infection. Examine her with these in mind and start appropriate treatment immediately after the diagnosis is made. In case there is persistent bleeding or continuation of pregnancy, do repeat SE and curettage. During routine follow-up visits after 2 weeks, besides routine examination, do a pelvic examination and rule out continuation of pregnancy, incomplete abortion, pelvic infection, and to check for CUT if it has been inserted along with MTP. Complications and their treatment. Complications of SE and D. Available facilities: gestational, age, type of anesthesia, patient's age, parity, socioeconomic status and pre-existing disease. The major complication rate is less than 1 in 100 procedures. The risk of mortality from these procedures is 11 times lower than the risk of dying from pregnancy and childbirth. The following complications may be met during suction evacuation. I. Uterine hemorrhage. It is usually due to incomplete evacuation of products of conception. It occurs more often when the gestational age is more than 8 weeks and when general anesthesia is used. It can be reduced to a great extent by the use of oxytocin drugs. 5 to 0 units of synthesinon in 5% dextrose as IV drip during the procedure and by prior use of laminaria tents for effective dilation of cervix when the size of uterus is 10 to 12 weeks. Laminaria tents are made from seaweed dried and rounded into stick shape. These are intensely hygroscopic. When placed in a moist environment such as cervical canal, it gradually swells up to several times its original diameter. These are available in 3 diameters: small 3 to 5 mm, medium 6 to 8 mm and large 8 to 10 mm. A thread is placed at one end to facilitate removal. The laminaria tents are inserted into cervical canal. Care must be taken that the distal tip of the tent be inserted through the internal OS and proximal tip remains outside the cervical OS. The tent is kept for 6 to 12 hours and removed. You can either do SE or evacuation after removal of laminaria tent. One of the drawbacks of laminaria tent is infection. Hence, always use prophylactic antibiotics. Pelvic infection. It occurs in 0.1 to 1% of cases, mostly due to incomplete evacuation and improper aseptic technique. The symptoms usually appear on the second or third day but may be delayed up to 10 days. The woman has fever, foul-smelling discharge, abdominal pain, pelvic tenderness, subinvolution of uterus and bleeding per vagina. The infection can be controlled by the use of antibiotics and re-evacuation if the abortion is incomplete. Cases of peritonitis and septic shock should be referred to higher center. Cervical injury. Incidence is 0.1 to 1%, occurs more often with D. But if perforation has occurred or if injury to the omentum or intestines is suspected, laparotomy followed by the necessary procedure should be performed. Retained products. These are seen in 2 to 4% of cases. It can be reduced by check. Curettage after SE. These cases need repeat SE and antibiotics. Continuation of pregnancy. Incidence is less than 1%. Diagnosis is by routine follow-up and asking patient to report if pregnancy symptoms continue or amenorrhea continues for more than 4 weeks after MTP. Repeat SE is needed. Maternal mortality and morbidity. Morbidity is lowest between 6 to 8 weeks of pregnancy. Risk of complications rises by 15 to 30% for each week of delay. Mortality is very rare, incidence being 1.3, 1 lakh procedures. Note, morbidity and mortality rates increase steeply after 8 weeks of gestation. Long-term complications. The WHO study showed an increased chance of future abortions, especially in the mid-trimester and preterm labor. The cause may be cervical incompetence. Also remember that the chances of sterility and ectopic pregnancy are more, maybe because of infection, adherent placenta and rupture of uterus due to previous undiagnosed perforation during MTP. Hence, strict aseptic precautions are to be taken while doing an MTP. C. Manual vacuum aspiration. The manual vacuum aspiration (MVA) technique is a safe and simple technique for termination of early pregnancy and also for evacuation of inevitable and incomplete abortion. The MVA technique. The MVA is performed using a syringe that can hold vacuum and an appropriate sized flexible plastic cannulae, Karmans. The vacuum produced in the syringe is approximately 25 to 26 inches, 600 to 650 millimeters of mercury, Hg, which is the same as the level of vacuum in an electric suction machine. The termination of pregnancy is performed by aspirating the products of conception using the cannula and the syringe. The technique is described in detail in Practical Manual, MME202. Advantages and disadvantages of MVA. Advantages. I. It is a simple technique that has proven to be safe and effective in termination of early pregnancy, as well as in management of incomplete abortion and inevitable abortion. It is not dependent on availability of electricity. It can be performed in any facility with basic facilities for minor surgery, normal delivery. IV. It can be performed without any anesthesia. In selected cases, local infiltration may be required. It is one of the effective techniques of surgical intervention for termination of pregnancy up to 8 weeks of gestation. Its effectiveness in completely evacuating the uterus is reported to be more than 98%. Its complication rate is low. Results of comparative studies of various techniques for termination of pregnancy, done in 3 hospitals in Delhi, have reiterated the fact, it is easy to inspect the aspirate for products of conception as tissue remains more or less intact. Disadvantages. The main disadvantages related to the equipment are that the MVA syringe needs to be replaced after doing procedures, number of procedures, and the cannula needs to be replaced after doing procedures, number of procedures, The MVA can cause serious complications such as the following, which may be encountered with any of the surgical methods of intervention for terminating pregnancy. However, the complication rate is lower in the case of MVA. The serious complications are hemorrhage, infection, perforation. With careful selection of clients and care during procedure, the above can be avoided. Indications and contraindications for use of the MVA. Indications. Termination of pregnancies up to 8 weeks of gestation. Although the MVA can be used for termination of pregnancy up to 12 weeks by specialists, it is not recommended for medical officers as the risk of complications is high. The MVA can also be used for evacuation of uterus in inevitable and incomplete abortions. Contraindications. In the following conditions, the MVA should not be used in PHCs and in facilities with no emergency backup. Uterine size more than 8 weeks, even if the reported duration of pregnancy is less than 8 weeks, as the risk of complications is high. Septic shock, severe tenderness of lower abdomen and distension, suspicion of perforation from a previous interference, suspicion of ectopic pregnancy, pregnancy with fibroid uterus, history of caesarean section or uterine surgery, severe cervical stenosis, medical disorders such as anemia with hemoglobin below 8 grams, bleeding disorders, hypertension, heart disease, renal disease, diabetes mellitus. The MVA should be used carefully in the following conditions after ensuring arrangements for immediate referral. Young adolescent, nulliparous women. In case of clients with purulent discharge per vagina, treat the infection first before doing the procedure. Complications. Immediate complication due to local anesthesia, excessive bleeding, uterine perforation, fainting. Delayed complications. 1. Incomplete evacuation. This is the commonest complication. Patient usually presents with excessive or prolonged bleeding per vagina, fever or pain in the abdomen, usually within 2 weeks of the procedure. The condition is preventable by using the correct technique of evacuation and checking the quantity of the evacuated material. Counsel and refer such cases to a higher facility. Manage bleeding, as above, if there is heavy bleeding. 2. Continuation of pregnancy. Pregnancy may continue due to failure to terminate the pregnancy due to the following. Early pregnancy that makes it difficult to suck out the embryo as it is too small and is lying near the conva of the uterus. Presence of fibroids that distort the uterine cavity and block the suction of the embryo. Failure to suck effectively due to small-sized cannula, partially blocked openings and ineffective suction pressure. Counsel and refer to a higher facility. 3. Infection. The symptoms of infection generally appear within 2 to 3 days after the procedure. Infection should be prevented by taking utmost care while performing the procedure by ensuring that all the instruments used are properly sterilized and that no-touch technique is observed. The parts of instruments that will be introduced in the uterus should not touch objects or surfaces that are not sterile, including the vaginal wall, before being inserted. Initiation of antibiotic therapy before the procedure is another critical step in preventing infection. The signs of infection are fever, abdominal pain, pelvic tenderness or subinvolution of uterus and bleeding per vagina. In severe cases, patient may present with signs of peritonitis or septic shock. Manage as follows. Give a dose of doxycycline 100 mg and metronidazole 400 mg orally. Refer. Remote complications. Complications may occur during future pregnancies, example, adherent placenta in uterine rupture due to previous undiagnosed perforation in MVA. Psychosomatic symptoms. Depression may be seen sometimes, especially if the termination has been carried out for medical reasons or has been enforced by the woman's husband or family members. Counseling has a critical role to play in preventing such problems. Recurrent mid-pregnancy abortions. Recurrent mid-pregnancy abortions can occur due to cervical incompetence as a result of injury to the cervix, IV, ectopic pregnancy. Infertility. Amenorrhea due to Asherman's syndrome, uterine syneche. 5.6 Methods of second trimester. Pregnancy termination. Second trimester pregnancy termination is done either by induction of abortion by uterine stimulation or by surgical methods. Induction of abortion is done by injecting drugs into intra or extra amniotic space and introducing devices like LT or catheters. Surgical methods include hysterotomy and hysterectomy. The methods could be classified as mentioned below. 1. Intra-amniotic installation of drugs. Ethicradine lactate, Emcredal, prostaglandins, PGF2A, urea 40%. 2. Introduction of devices through cervix to induce abortion. Laminaria tent, catheters. 3. Surgical method. Abdominal hysterotomy, abdominal hysterectomy. Ethicradine lactate. Ethicradine is the most commonly used drug for second trimester MTP. This drug is given by extra amniotic route. Amount instilled is 10 ml of 0.1% ethicradine for every week of gestation up to a maximum of 150 ml. Its mode of action is by producing prostaglandin from decidua. Intravenous oxytocin drip is started after 12 to 24 hours to accelerate abortion. Induction. Abortion interval is approximately 30 hours. 86% of patients abort within 72 hours. If the patient does not abort within 72 hours, reinstallation of ethicradine can be done. With reinstallation, the success rate is almost 100%. It has no contraindication and is safe. For mid-trimester abortion, extraamniotic installation of ethicradine lactate is good because it is safe. Complications and very rare, failure rate is about 5 to 6% where reinstallation is required. Late sequelae of MTP. Incompetent cervical OS, anemia, menstrual disturbance, secondary amenorrhea. Asherman's syndrome, infertility, psychological disturbances and Rh isoimmunization. Rh isoimmunization can be prevented by giving 150 mg of Rh immunoglobulin to Rh negative women. 5.7 Summary. In this unit, we have learned about medical termination of pregnancy. Here are the main points of this unit. Medical Termination of Pregnancy Act was introduced in India in 1971 and further rules were amended in 1975 and 1977. MTP or induced abortion is defined as willful termination of pregnancy before viability, i.e. before 20 weeks of pregnancy. LWE learned the guidelines for MTP, i.e. where, when and who can perform abortion. Proper channel, counseling in patient selection is very important for safe MTP. We learned in detail the methods of first trimester pregnancy termination. First trimester MTP is safest when performed before 8 weeks. Safest and best method of first trimester MTP is MVA and SE. We have learned in detail the complications and their prevention and management. We learnt about the methods of second trimester MTP by extra amniotic injection of ethicradine lactate. We also discussed about the importance of contraceptive advice along with MTP. Thank you for watching. We will see you in the next video with the next chapter.